Standard Western geriatric psychiatry operates almost entirely on a disease-driven single-organ model. A patient presents with a specific symptom, like anxiety or insomnia, and receives a highly targeted prescriptive pharmacological fix. Over time, this targeted approach aggregates. Aging patients accumulate prescriptions, leading to cascading drug interactions and polypharmacy, where each additional medication yields diminishing returns and introduces new cognitive side effects. But if we look at the broader data, this chart shows the breakdown of factors driving disease, premature death, and overall healthcare costs. Up to 65% of these negative outcomes are directly attributable to health behaviors, far outweighing genetics and environmental factors combined. Addressing those behavioral factors requires a systemic shift. Complementary and integrative medicine, alongside lifestyle medicine, enters the clinical framework here to manage these exact variables. Integrative and lifestyle medicine offer a rigorous, evidence-backed framework essential for preventing chronic psychiatric disease and actively reducing the drug burden on older adults. The whole health model treats the interconnected biological web, a significant departure from the isolation of individual symptoms seen in traditional medical practice. Integrative medicine identifies and corrects underlying physiological deficiencies, allowing clinicians to optimize a patient's baseline function alongside or in place of standard psychotropic treatment. Many clinicians naturally resist these modalities. The field lacks the massive funding and standardized regulatory oversight typical of the pharmaceutical industry, making it harder to parse out what actually works. To deploy these methods effectively in geriatric psychiatry, we have to bypass the broad assumptions and deconstruct the specific clinical data behind non-pharmacological interventions. Success with older adults requires shifting the clinical objective. Clinicians must actively construct a resilient physiological baseline, moving past the focus on fixing broken systems. Nutritional supplementation in psychiatry faces a significant evidence problem. Large clinical trials frequently fail to show efficacy for interventions like fish oil in treating mood disorders or preventing cognitive decline. When researchers measure supplement efficacy across a wide, heterogeneous patient population, the average trend line remains flat. The data changes using responder analysis. By isolating the specific group of patients with pre-existing biomarker deficiencies, a steep, highly significant efficacy trend line emerges. Supplements rarely enhance an already healthy system. They show clinical utility primarily when they correct an existing biological deficit. With that principle in mind, clinicians should utilize several evidence-backed nutritional interventions for older adults. This table outlines nutritional supplements for preventing or treating mental illnesses. Vitamin D3 prevents cognitive decline when blood levels fall below 20 nanograms per milliliter. Omega-3 fatty acids treat depression, while ginkgo biloba and B-complex vitamins manage cognitive symptoms. Prescribing supplements blindly without testing is clinically ineffective. True utility requires targeted diagnostic screening to identify and treat precise nutritional deficiencies. Beyond nutritional baselines, physical interventions provide another lever, specifically the correlation between exercise and preventing dementia. Observational studies struggle with a causality dilemma. Does exercise prevent cognitive decline, or does emerging cognitive impairment simply reduce a patient's ability to exercise? The 2021 Chicago Health and Aging Project bypassed this dilemma.
Instead of relying solely on cognitive tests, researchers measured physical activity against a specific neurodegenerative biomarker, total serum tau concentrations. Tau is a protein that helps stabilize the internal skeleton of nerve cells. High levels of tau protein tangles disrupt neuronal pathways and are highly associated with the progression from mild cognitive impairment to Alzheimer's disease. The study tracked participants over age 65, categorizing them by self-reported physical activity: none, under 150 minutes per week, and over 150 minutes per week. This graph charts cognitive decline rates over time. For patients with high baseline tau, the sedentary group drops sharply. However, the active high tau group, those exercising over 150 minutes a week, maintains a significantly flatter, more stable trajectory. Even patients with low baseline tau experienced a smaller yet statistically significant protective benefit from high levels of physical activity. Prescribing moderate to high physical activity is a targeted physiological intervention that directly offsets neurodegenerative biomarkers. Knowing the data is one thing. Implementing these physical and nutritional protocols in practice is another. This is the primary clinical challenge of lifestyle medicine. The core bottleneck in this framework is that the burden of behavioral change falls almost entirely on the individual patient. That burden is often complicated by systemic barriers. Socioeconomic deprivation, racism, or simply a lack of safe walking environments make simple behavioral changes incredibly difficult. The Veterans Affairs, or VA, healthcare system operates the largest successful experiment in lifestyle medicine, managing millions of aging patients through its whole health initiative. The clinical methodology of whole health shifts every patient interaction away from symptom management. Clinicians focus on understanding the patient's core purpose in life. To secure compliance, clinicians must attach the required health behavior directly to something of vital personal importance to the patient. Consider the case of an older Vietnam veteran suffering from peripheral neuropathy who initially refused standard physical therapy. The clinician secured compliance by linking balance exercises not to the abstract goal of fall prevention, but specifically to the veteran's personal goal of safely boarding his boat at night. Providing medical data is insufficient. Lasting behavioral change in geriatric psychiatry requires actively anchoring the clinical intervention to the patient's psychological purpose. The clinical efficacy of integrative psychiatry rests on three pillars: targeted nutrition, biomarker-backed physical activity, and purpose-driven behavioral engineering. Integrating these pillars treats the biological and behavioral baseline simultaneously. This graph illustrates the effect over time. While a traditional pharmacological curve plateaus and dips due to side effects, an integrated lifestyle approach intersects it with an upward curve that elevates the patient's functional baseline. This lowers the required dosage and dependency on acute psychopharmacology. The new clinical workflow begins with precision. Screen for exact nutritional deficiencies, like vitamin D3 and omega-3s, before automatically prescribing psychotropics. Next, clinicians must prescribe targeted movement protocols of over 150 minutes a week, specifically to offset neurodegenerative tau proteins. Finally, architect compliance by mapping these interventions directly to the patient's core motivations and life goals. This shift toward a well-being-driven model depends on active patient participation. The modern psychiatric clinician's role has expanded. They now architect a sustainable, systemic physiological baseline for the aging brain.